Tenosynovial giant cell tumor, previously known as pigmented villonodular synovitis, is a neoplastic process that happens in a single joint generally. And what happens is there's a neoplastic clone that has overexpression of colony stimulating factor 1. So it recruits inflammatory cells that bear colony stimulating 1 receptors on their surface over to the joint. And it's a devastating process for a certain group of patients in which they get large tumors, significant swelling, edema, and joint pain. And it can be very debilitating for them. There's actually 2 variants to the disease. There's a nodular form, which is a really well circumscribed type of tumor. And this is something that is almost always cured with surgery alone. And then there's a diffuse variant, which is a very infiltrative process within the joint. And this is the disease generally that we as medical oncologists talk about when we talk about tenosynovial giant cell tumor. It's this diffuse variant, which can carry significant morbidity for patients. Surgery is still the main option for treatment. But in some of the diffuse recalcitrant cases, you can have recurrence rates as high as 50 to 60% with surgery. Yeah, there's definitely the clinical symptoms, which we can often see, which can be significant swelling, pain, decreased range of motion. Those, and some patients have very large joint effusions. Those are a lot of the symptoms that can affect quality of life. And gauging those symptoms in the sense of how well a surgery can alleviate those and what has been the pattern for the patient and what is the expected relapse rate. In some patients, surgeries can really alleviate those symptoms for a significant amount of time. In other patients, not so much. What also happens over time is you can get joint destruction, right, which is a different feature than what the tumor is actually itself doing. So the orthopedic surgeon also has to think about ways and when they may need to preserve the joint, right? And that becomes an important concept as well. Because the orthopedic oncologist really still remains the entry place for many of patients with TGCT into the clinical care spectrum. When we think about what we have to offer from a medical oncology, it's their evaluation of when they feel repeated surgeries won't help the patient, right? And that's the time that they will often send the patient to a medical oncologist to start to think about medical management. Generally and unfortunately, this is a disease that has been neglected, for many years. And because of that, it was very hard to diagnose. So patients would often circle back in between their local physicians in the sense of primary care doctors. They would often see rheumatologists and generally end up within an orthopedic oncologist. An orthopedic surgeon. From there, when the diagnosis is made, they really enter into the realm of an orthopedic oncology, who's, I think, been one of the central clinicians in treating this disease. Unfortunately or fortunately, surgery, really was the main treatment choice. Now that we have medical treatments for patients, medical oncologists have also come into the treatment paradigm. But what's been interesting in trying to develop drugs is we've spent a lot of time understanding the journey that patients go through, and in such trying to define the team that needs to be around the patient. And this definitely includes their internist. We have physical therapists, occupational therapists, sometimes pain and palliative control doctors. Rheumatologists can play a role, as there are often other diseases that can mimic this. We also have physical and medical rehab medicine, PMR, that plays a role, physiatrists as well. So it's actually a large team that patients should be involved in their care. And at our hospital, we also use a lot of integrative medicine to also help with symptoms and improve outcomes.